Yes, exactly. So what we get to learn from this is like we need to be vaccinated and it should be mandatory overall. So nobody get this type of cases we can't do. Yes, exactly. So what we get to learn from this is like we need to be vaccinated was unvaccinated. So we need to be vaccinated. That's correct. I agree with you.
Wow, those are so wonderful points across. Thank you so much, guys. Are there any comments or other questions regarding this great piece shared by Harshal?
Hi, Patricia, we're ready.
Thank you so much, Lauren. So I see that Lauren is ready. That means our speaker is here, and I will be handing over the mic to Lauren. So as we move into our keynote lecture portion, the YouTube live stream link will be pinned above shortly, and you can see Dr. Bernstein's presentation in real time. If you have any questions regarding today's talk, you can back channel to our wonderful, wonderful moderators on stage, and we can get them on queue. We will be turning off hand raising during the lecture, and if you are a known contributor to the conference moderators, please back channel us. We will invite you on the stage and get your question in queue. So now I'll be passing on the mic to Lauren.
Hi, Patricia. Can you hear me okay?
Yep, loud and clear.
Great. Hello, everyone, and thank you so much for joining us for the MedNews Week conference. Our goal here is to bring you the most cutting-edge medical information from the leading physicians and researchers in their fields. My name is Lauren Vento, and I will be your host today. Just a quick note on our two founders and co-hosts, Dr. Jan Leifman, who is a renowned cancer researcher, and Dr. Chandler Park, who is president of Kentucky ASCO, has published over 100 peer-reviewed papers, including in the NEJM, and he is the host of the nationally televised Masters Lecture Series. We are fortunate to have a great team to make these events a reality. Our chairs include Dr. Chandler Park and Dr. Leifman, as well as Pratusha Ganta, who is also the moderator today. Our organizing committee is composed of myself, Alexandra Vandekieft, and Dr. Yavu Salai. Our educational committee includes Sean Jakayewicz, Amarel Charoon, Pallavi Pai, and Melissa Mana. The managers of MedNews Week are Alexandra Vandekieft and Pratusha Ganta. The associate managers are Muskan Joshi, Billy Wilkerson, and Gayatri Menon, and a special shout out to Billy, who is our tech expert. Our director of video production is Sean Jakayewicz. Our media director is Pallavi Pai, and again, our moderator today is going to be Pratusha Ganta. Today, we welcome to MedNews Week stage Dr. Bernstein. Dr. Bernstein is a world-renowned gastroenterologist and hepatologist. He has been recognized as one of Castle Connolly's best doctors in New York and received many prestigious awards during his career. His interest is primarily in the management and treatment of liver diseases, with most of his work concentrated on developing new treatments for viral hepatitis, primary biliary cholangitis, and fatty liver disease. Seen as an authority on these topics, it's no surprise Dr. Bernstein has been involved in shaping public policy and in education on these topics. He has been involved as a special consultant and task force member for the state of New York to develop guidelines for treatment for hepatitis C, as well as a 5-year strategic plan for viral hepatitis. He has been on many committees within the American College of Gastroenterology and served as the ACG governor for Long Island. He has directed numerous clinical trials and has been an author or co-author of over 300 articles, many abstracts, and book chapters. His work has been published in JAMA and NEJM, as well as the American Journal of Gastroenterology, to name a few. And he is a peer reviewer for many well-known journals. Dr. Bernstein graduated from SUNY, Stony Brook School of Medicine, and has received an award for being a distinguished alumni. He completed his medical residency at Montefiore Medical Center and his fellowship in gastroenterology and hepatology at the University of Miami. During his career, he has been instrumental in leading GI departments to success. At North Shore University Hospital and Long Island Jewish Medical Center, under his leadership as the Chief Division of Gastroenterology, Hepatology, and Nutrition, the department made the list of the top 50 GI divisions in the nation. At Northwell Health, he founded and built the hepatology department, started the liver transplant program, and developed a curriculum for medical students, residents, and fellows. He was named the American Liver Foundation's Physician of the Year in 2016 and has been honored by Crohn's and Colitis Foundation of New York, the Nassau County Holocaust Memorial Center, and North Shore University. Currently, Dr. Bernstein is the president of JSDB Consulting. He serves as the current district president of Nassau East New York chapter of ACP, and he is also currently the treasurer of both the Empire Liver Foundation and the Bacchus International Society of Gastroenterology. We are honored to have him here today to learn from him about non-alcoholic fatty liver disease. Dr. Bernstein, I'm going to turn it over to you.
Thank you very much. Thank all of you for attending. What I hope to do over the course of this presentation is really introduce a topic that is quite common, and that topic is non-alcoholic fatty liver disease. The most common liver disease worldwide. So let's get right to it, and then I guess there's a question and answer session when we are done. Let me try to move this along. There we go. So if we talk about non-alcoholic fatty liver disease, and this is data from the United States, non-alcoholic fatty liver disease is the most common chronic liver disease in the US. It's moved up the ladder to become the second most common reason for liver transplantation in the United States after alcohol. Unfortunately, it has become the leading predisposing factor for the development of primary liver cancer. And this cancer can occur even in the absence of cirrhosis, which really makes it quite worrisome, since I'll show you the numbers of people in the US who have this disease. And then the majority of patients with fatty liver disease have normal liver enzymes. So if you don't think about it, and if you don't assess, you're going to miss it in the majority of people. And again, the majority of people, because of that, remain undiagnosed, not only in the US, but around the world. So if we look at what the numbers are, and we just talk about fatty liver, which encompasses all people that have fatty liver, and I'll begin to explain the differences. It's 1 in 3 Americans. So the estimate is to be about 110 million people. The United States has a population of roughly 330 million people. As we go down a disease spectrum, about 20 million folks will have non-alcoholic steatohepatitis or Nash. And here's where we begin to become concerned about these patients. Because once they have inflammation, once they have scarring, then they become at risk for the development of liver cancer and all of the complications of liver disease, including cirrhosis. So I guess the good news is the majority of people just have fatty liver and won't be a problem, but still about a fifth of the patients will go on to develop significant disease called Nash. And then if we take one step further down, as you can see here, there are estimated to be between 4 and 5 million people in the United States that have bridging fibrosis or cirrhosis secondary to fatty liver. So that's a big number. That dwarfs all other causes of liver disease combined, which lead to cirrhosis in the United States, as far as we're aware. And these are the folks that are at risk for liver failure, complications of advanced liver disease, encephalopathy, variceal bleeding, ascites, and the dreaded hepatocellular carcinoma. And so this is the population that we're really trying to address. The number of people who have the disease, as you see, are quite large. And there's a significant unmet need, not only in how we evaluate patients, but how we treat patients and just what to do with them. Because the sheer volume of patients overwhelms many of the practitioners that we currently have. If we look at the natural history then of fatty liver disease, and you can see that here, people are born with a normal liver. The progression of this condition is then you go from a normal liver to fat, which is the non-alcohol fatty liver. You see that as NAFL. Then patients can progress to Nash that we talked about, with or without fibrosis. And those patients are at risk for developing cirrhosis and all of its complications. How long does it take then to go from just fat to fat and inflammation and scarring to cirrhosis? And we really don't know that good answer because we don't have long-term natural history studies. But we're beginning to believe that patients can progress every 5 to 7 years from fatty liver to these complications if they're going to progress. Since the majority of patients now are really being diagnosed when they're 20, 30, and 40 years of age, you're talking about a very large number of people who are going to have significant liver disease still at a young age. And then if we follow down to the bottom of this, which shows patients who can develop a hepatocellular carcinoma, you can see that whether someone has fatty liver, inflammation and some mild fibrosis, or cirrhosis, all are at risk for developing hepatocellular carcinoma. The incidence do vary. So in non-cirrhotic patients, the incidence is very low. It's about 0.1% per year. Whereas those that have cirrhosis, it's 1 to 2% a year. But having said that, 30 to 50% of patients who develop liver cancer from fatty liver do not have cirrhosis. And so we have yet to figure out how to best screen these patients and how to best advise these patients to be evaluated for liver cancer. What are the risk factors? There are many risk factors for fatty liver disease, but the two biggest risk factors are having diabetes or being obese. And much of the United States and much of the world are obese. There are multiple other risk factors. I'm really not going to list them all, but you should know there are special groups, those with hypertension, those with dyslipidemia, so the high cholesterol, high triglyceride population, and another subset that have polycystic ovarian syndrome. These aren't all of the risk factors for fatty liver. And if you're going to really pay attention to the ones that are most important, it's diabetes and obesity. And as many as 50 to 70% of patients with type 2 diabetes have fatty liver, which is why it's so critical for our endocrinology colleagues to be aware of this, look for it, diagnose it, and quite frankly, treat it. What is the prevalence then amongst an obese population of fatty liver and NASH? 70% of folks who are obese have fatty liver. About 30% will have NASH. So you're talking about a tremendous number of people. And the predictions are, and 2030 used to be far away, but it's not so far away anymore, that almost 50% of the adults in the United States by 2030 are going to be obese. And if you follow the slides that the CDC has, you can follow all 50 states, and they change color over time over the past 20 years. And there are no states that don't have at least 30% of the population being significantly obese today. And so we are really preparing for, as best we can, an epidemic of advanced liver disease 1 to 2 decades from now. And if we're smart, and if we can figure out therapies and get people to pay attention to this, perhaps we can prevent all the complications that are now being predicted, because there aren't enough caregivers to care for folks. We do know that a Western diet and a Western lifestyle is associated with weight gain and obesity, and then fatty liver. And there are tremendous variations across the globe, but there isn't a single country and a single continent that has not seen a rise of fatty liver disease. As an aside, the country that's seen the greatest rise in diabetes and fatty liver disease is China. And so we're just seeing it. The area of the world which has the greatest prevalence of fatty liver disease is the Persian Gulf and the countries in that area. So it's not just the United States. This is a worldwide problem that is only getting worse. And I show this because this literally came out this week in Clinical Gastro and Hepatology. And this is an article on the effect of fatty liver disease on pediatric diabetes. So approximately 900 children with a mean age of 12 years of old, mostly boys, were followed for about 13 years to see what happened to them as regards to the development of diabetes. The mean BMI was 31, so they are all obese by definition. 17% of these patients, while still children or very young adults, developed type 2 diabetes. That's one in 6 children. So there's an epidemic of diabetes. And we're going to see it more and more since so many of our young kids are overweight. Who is at greatest risk for the development of type 2 diabetes with fatty liver? It was actually the women, so the girls. And so it's going to be important to intervene early. And this study is fairly large, and it shows us that the incidence of type 2 diabetes in children with fatty liver disease is actually 30 times greater than that has been previously reported. So this is a real problem. So if you say that the kids are now getting diabetes at 20, 25, they have fatty liver, you can predict that by 35, 40, they're going to have not only potential complications of diabetes, if not well controlled, but they're going to have significant problems with advanced liver disease. So this is something that we need to act upon sooner than later. Right? Having said that, there's another condition which is a little concerning, and that condition is called lean fatty liver or lean NASH. Lean meaning that they are developing fatty liver and NASH with normal body weights. And so these are thin people that are developing fatty liver. And this subset of fatty liver disease has a worse prognosis than those people who are actually overweight. And so how do we define lean NASH? In non-Asian adults, we define lean NASH as occurring with a BMI of less than 25. And in Asian adults, we define lean NASH as fatty liver occurring in people whose BMI is less than 23. Now, I'll say straight away, we don't know the pathogenesis of fatty liver. So why do thin people develop this? Why do people who are overweight develop this? We just don't know. There's a lot of research being done, and there are more unanswered questions than questions we're actually able to answer. So right now, most of the data we have is observational. But there's a tremendous amount of work being done. If we look at the overall prevalence then of lean NASH, and this comes from a couple of studies about 2 years ago, the prevalence of lean NASH in patients with fatty liver disease is about 18 to 20%, so almost a fifth. The prevalence of lean NAFLD in all people is 4 to 5%. So think about how many people live on Earth and how many people are thin and how common this is. And amongst thin people, still about 10% are going to have fatty liver. So we are looking at significant concerns for health in the not too distant future. Lean NASH has a cardiometabolic rate that's similar to fatty liver in obese people. Patients with obesity and fatty liver are at significant risk for the metabolic syndrome, hypertension, diabetes, and dyslipidemia. Well, so are those with lean NASH, right? And so you can see that here. 50% of them have elevated lipids, a third with metabolic syndrome, a little more than a third with hypertension, and 12% have type 2 diabetes. So it's a problem. And if we then look at the probability of developing complications in NASH by BMI, you can see there in the top right, the patients with lean NASH, when compared to those who are overweight or obese who have NASH, are at a greater risk of developing a cardiovascular event. So thin people with fatty liver are more likely to have a cardiovascular event, whether that be a myocardial infarction or a stroke. If we look at the other parameters, cirrhosis and the development of cancer, well, those that are overweight or obese are more likely to actually then develop that. And there's no difference over time in when these complications occur, whether someone is thin, overweight, or obese. And so, once again, lean NASH is very important to be identified. So I just laid out a picture for you of fatty liver disease, which is so common. And so the question really then to be asked is, should we be screening for this? Well, nobody's really quite sure. So here are some guidelines or recommendations from some societies around the world. The American Association for the Study of Liver Disease says no screening, but maintain a high suspicion if patients are diabetic. The Europeans, which is the middle, say that patients with obesity and metabolic syndrome should be screened with liver enzymes and sonogram. And those that are high risk, more than 50 years of age, with cardiovascular disease and or diabetes, should also be screened. The American Diabetic Association, much more proactive, and they recommend that anyone with type 2 diabetes or pre-diabetes with an elevated ALT, remembering that a normal ALT in a woman is 25, upper limit of normal, in a man 35, should be screened for NASH and for fibrosis. And if found, treatment should be initiated. So we're just getting these recommendations, from our societies. I think the AASLD has a long way to go, quite frankly, in their recommendations. How do patients present? Well, most are asymptomatic. They feel fine, and they're discovered really by chance, right? Usually it's an incidental finding, mildly elevated ALT, mildly elevated alkaline phosphatase, sonogram done for another reason, where there's a question of fatty liver, or on physical exam or imaging, that the liver is large. But having said that, the majority of people have normal liver tests and have no symptoms, right? So how do you find it, right? And if you find it, how do you then assess the disease severity, in these patients? And can you do that in 1/3 of people living in the United States? Well, we use simple non-invasive tests right now. We do not do a lot of liver biopsy in these patients. The simple tests are the Naval fibrosis score, which I'll show you, which you can calculate on your own. The fibrosis 4 test, or FIB4 test, which is probably the most used test, but you can also calculate on your own. And I stress calculating on your own because if you go to the middle, you can see the proprietary test, which you can order, FibroSure, FibroSpect, or Enhanced Liver Fibrosis Test, or ELF. These are costly and really don't add much more than the simple test, other than the ELF test, which is actually quite good. And on the right, we use imaging, transient elastography or MRI. Two types of tests that are readily available. MRI is expensive, not in all communities, but transient elastography is beginning, at least in the United States, to become more available. The reality is we usually use a simple test and some type of imaging test and put the two together, because two tests are always better than one in this type of situation. The Naval fibrosis score has 7 parameters: age, AST, ALT, platelet count, BMI, albumin, and whether or not the patient has fasting glucose, impaired fasting glucose, or is diabetic. And you plug it into the computer or your smartphone, and it will give you a number. And it's very good at determining if someone has no fibrosis or significant fibrosis. In the middle, not so good. The FIB4 does the same thing, but only uses 4 parameters: platelet count, ALT, AST, and age. And you get the same thing. If the number is low, less than 1.3, pretty much rules out fibrosis. If the number is high, more than 2.67, these patients are likely to have bridging fibrosis or cirrhosis. But again, in the middle, none of these tests are actually good. So we talk about imaging. And how do we image? And how does imaging help us in patients with fatty liver? So fatty liver disease can be diagnosed on imaging. You can see it on sonogram with increased echogenicity. You can see a big liver, and you can see low attenuation when compared to the spleen. NASH cannot be diagnosed by imaging because NASH is inflammation, and there are certain parameters that need to be defined, and NASH can only be diagnosed then by biopsy. You can get a CAT scan, and you will see low attenuation of the liver, when compared to the spleen. But it's expensive to do a CAT scan, and a CAT scan has radiation. So we really don't use CAT scan much in these patients. Many of these patients are diagnosed by CAT scan because CAT scan is done for another reason, and then they say, oh, look, the patient has fatty liver. So you can find fatty liver, but you can't find Nash. Transient elastography, of which there are several types, I'm going to show you one, which is FibroScan, is a simple test. It's non-invasive. It can be done in the office. It requires a 4-hour fast, well, where you can't have any liquids or foods beforehand. Not that you can't technically do it, you can, but if someone eats and or drinks, what happens in the body is blood flow gets shunted towards the liver, and that increased blood flow after eating is going to cause the machine to read more scarring than is actually there. There's a code for this. There are special probes, whether someone is obese or not, so you need to have the different probes. And this can be performed by a non-radiologist, a gastroenterologist, a hepatologist, an endocrinologist, a primary care office if they're interested in, since it is reimbursed. And then we use parameters. You know, we get what's called the KPA. And if it's low, less than 6, there's no scarring. If it's 12 or above, there's cirrhosis. And then we can also say moderate or severe based upon the other numbers. And you can follow this serially. And we see all the time someone gains weight, the numbers go up. Someone loses weight, the numbers go down, which tells you that fatty liver and fibrosis is a dynamic, not a static process. You can get better from this. And, you know, that's very important, especially for patients. You have to be careful not to overestimate. So you have to know when you can use this or not. So again, non-fasting doesn't work. In patients that come in with acute hepatitis, because the numbers are so high, you're going to get increased readings of scarring. Same thing if there's congestion from congestive heart failure or if there happens to be a lesion. But this is a really easy, simple test to determine how much scarring is present. And so we use it always in combination with the FIB4 because we can calculate, because we have those already. MRI elastography, even better because it gives you a picture of the whole liver, but it's expensive and people have to go into an MRI machine. You can see on the left an example of no fibrosis, and you can see on the right someone that has significant fibrosis, and you can see all of that red. And so very good test. We use this a lot when there's a discordance between the FibroScan imaging or the transient elastography and the blood test like the FIB4. And then MRI elastography, very useful for us. So we talked about how you can diagnose fatty liver. How do you actually diagnose Nash? And unfortunately, in 2022, the only way to diagnose Nash is to do a liver biopsy. There is no other way. And when you do a liver biopsy, you can see inflammation, you can see apoptosis, you can see things that are all consistent with Nash. But the question we have to ask ourselves is, do we have to do a biopsy on everyone with fatty liver disease? As a hepatologist, surprisingly, I'll argue that the answer is no, because we don't have treatments for people yet. But if we're not sure what's going on, then we should do a biopsy and see. And we will be seeing more and more biopsies being done. Now, there's a concept being worked on now that's called a liquid biopsy. Liquid biopsy is actually parameters used from the blood. And there's a tremendous amount of research now looking for diagnostic parameters for Nash and also for liver cancer that you can find in the blood. So you're going to be hearing more and more, and you read the literature about a term called liquid biopsy. But for now, the only way to diagnose Nash is a solid biopsy. You actually have to biopsy the patient's liver to be able to do that. And this is complicated, but this is really good for the primary care person. How do you then assess Nash? Well, we talked about the biomarkers and the FIB4 or the Naval fibrosis test. We talked about imaging. And then we talked about sort of putting them together, right? This is very helpful because if you see someone with fatty liver, you do a FIB4 and there's no scarring, you can follow that patient. Repeat the test in a year, 2 years. Discuss with them about treatment, which right now is behavioral modification. If there is significant scarring, that patient needs a referral to a specialist and needs confirmatory tests with imaging, most likely transient elastography or MRE. And if there's any question, you do a biopsy. So it's a fairly simple algorithm that you can follow. And now most of these tests are available all over the place, quite honestly. So now let's move to treatment. How do we treat fatty liver? And first, we really treat everyone with fatty liver, but there are specific goals for those patients that have Nash. Remember, that's the group that already has shown that they have inflammation and fibrosis. So the goals of the treatment are to improve metabolic abnormalities, decrease inflammation. How do you tell that? Well, we use ALT as a surrogate marker. Prevent, stop, or reverse liver fibrosis. We can do that by assessing with a fibroscan. And most importantly, to prevent disease progression such that you can prevent the development of liver failure, cirrhosis, liver cancer, and all of those related outcomes. So how do we do that in 2022? So here are some of the things that we have in our armamentarium. The top left is the most important, right? And it's lifestyle modification, diet, exercise, and weight loss. We can talk about using anti-hyperglycemic agents like a GLP-1, and we can even consider bariatric surgery as we try to control obesity, because we know if you lose weight, fatty liver gets better. We can target Nash in the bottom right with liver-directed treatments, which are all off-label. There's nothing approved for the treatment of fatty liver in the United States. And we can use things like vitamin E or pioglitazone. We certainly need to discuss with patients about reducing cardiovascular disease risk, since the most common reason why people die with fatty liver are cardiovascular disease, not liver disease. So you need to treat hyperglycemia, you need to treat hypertension, you need to treat dyslipidemia. And so statins become very useful. And it's important to note that it's perfectly safe to use statins in patients with liver disease, even those that have cirrhosis. So there was a large study years ago from the Dallas Heart, more than 10,000 patients. Statins are safe in patients with liver disease. They should be used. And in fatty liver, you're going to see some good responses in the patients who are taking statins. So I talked about first-line therapy being lifestyle. You need to cut out what you eat, right? Decrease caloric intake with a goal of losing weight of about 7 to 10% of your total body weight, and I'll show you that. Drink a lot of coffee. Coffee has actually been shown to be liver protective. 2, 3, 4, 5 cups, and you're actually going to do well and may prevent the development of advanced liver disease. Look at a good diet, low to moderate in fat, some carbohydrates, and I'll talk about what diets people can take. Avoid anything with fructose. All the snacks you can buy in the supermarket, all of the sodas that have fructose. Fructose is horrible and probably the one chemical that's the worst for anyone with fatty liver disease. Really strictly follow alcohol intake. Men should drink no more than 30 grams a day, women 20 grams a day. And you can see here some examples. I would say that it should really be much, much lower than that. But these are the current recommendations worldwide. And then physical activity is critical. You need to exercise at least 3 to 5 times a week and do some good aerobic exercise. But exercise itself won't do it. You need to combine it with diet, and you have to have a result, which is weight loss. So what diet should we recommend? Right, that's the million-dollar question. And there's actually been a study, European study, looked at the comparing a low-fat diet versus a Mediterranean diet. Patients started with about 25% hepatic fat content. They were watched closely and carefully for 18 months. All of the patients who followed both diets showed a decrease in the amount of hepatic fat content. But you can see that those that followed the Mediterranean diet with low carbs had a significantly greater improvement in their fatty liver and also a significantly greater improvement in their overall cardiovascular risk. So it's this and several other studies that have led us to recommend the Mediterranean diet in patients that have fatty liver, in patients that have diabetes. It's really just a healthy diet, right? It allows you to have pretty much everything, but concentrates on fruits and vegetables, certain pastas and rice, protein via fish or other seafoods, moderate portions of eggs, dairy, and other dairy. And you can still have sweets and meats, but you need to be smart about what you do. You can still have occasional alcohol, but you need to drink a lot of water, right? You need to drink a lot of water, which is very helpful. So if you follow, and this is of all the things I'm going to show you for treatment, this is the most important slide. This says if somebody loses 10% of their body weight, what happens to the complications of fatty liver? So if someone loses 10% of their body weight and have NASH, 90% of them will have NASH resolution. 81% will have regression of fibrosis, not elimination, but regression by at least one stage. And 100% will have an improvement in the amount of fat in the liver. But unfortunately, only 10% of people can lose 10% of their body weight. Right? If you're 200 pounds, you need to lose 20 pounds. And so this is by far and away the most important treatment, weight loss. However you can do it, weight loss will help. So what are the off-label treatments that are available? Vitamin E, recommended 800 international units a day in non-diabetic patients, but you do need to biopsy the patients first and they have to have NASH. Pioglitazone, recommended in patients with and those without type 2 diabetes, but they have to have biopsy-proven NASH. Obeticholic acid, used for primary biliary cholangitis. Good data just released in this patient population in NASH using obeticholic acid, but we still need further data before we can say use it. And although GLP-1s are widely used now in fatty liver, the reality is we do still need further data. GLP-1s are used because patients lose weight. And if they lose weight, their NASH improves. It does make a lot of sense. Right? And then there are a host of, in the US, FDA-approved weight loss medications that you can see here. None of them are approved in fatty liver. But if you lose weight, your fatty liver gets better. So anything that you can do to help patients lose weight will be beneficial to their liver. Patients always want a pill. And, in this case, it's a hard swallow because there isn't a pill. They really need to change lifestyle, and changing lifestyle takes time. If there are other complications, if the patient has advanced fibrosis or cirrhosis, and they're a candidate for bariatric surgery works to eliminate fatty liver, to improve fibrosis, and even to reverse cirrhosis. So bariatric surgery is absolutely an option. The most common operation currently being used is a sleeve gastrectomy. It works well. And you can see here a study which showed the regression of fibrosis in patients who had bariatric surgery. They do extraordinarily well. Within 6 months, there's a dramatic decrease in the amount of fibrosis and fatty liver disease. And years out, if the patients don't overeat through the bariatric surgery, they do incredibly well. And here you can see an example of an MR on the left with significant amount of fat and fibrosis prior to bariatric surgery. This is MR. And to the right, you can see 6 months later, the amount of fat has pretty much disappeared, right? And the amount of fibrosis pretty much gone. And so you can see very quick, dramatic results with bariatric surgery in this patient population. So then begs the question, what's next? And we'll just spend a few moments before we finish up on what's next. And I must tell you, there's just a ton of research going on, as you can imagine, because the patient populations are so great. Most have been disappointing, and we really don't have great endpoints. But there are a few products that are investigational that have made it to phase 3, where the phase 3s are still going, or their data is going to be analyzed and released soon. You should expect to see in November at the liver meetings in the US, a lot of data coming out, on these products. And so there's hope. At least we think there's hope. This I alluded to earlier. This is the data that just came out a week ago on obeticholic acid for NASH. This is public data, not in an abstract form or a manuscript form. This is a press release from the company that is sponsoring the trial. But there was a significant improvement in the higher dose of obeticholic acid versus placebo in the main endpoint, which is at least a 1-stage improvement in fibrosis with no worsening of NASH. There was not any significant difference in resolution of NASH. And obeticholic acid, as I'm sure you know, the main side effect is pruritus. So it's fairly common. Patients don't need to have to be stopped for it, but yeah, and they can be managed, but it does occur. And there was a trend, it seems, in this initial data for higher rates of biliary events, including gallstones in the patients who received the high dose of obeticholic acid. So more to come, but at least promising. This may be the first drug approved for NASH. I don't know. But it's certainly the one that's most far along in its development. And then there are a whole host, and this is not inclusive of all, but there are a whole host of other investigational products in phase 2, and there are a lot in phase 1. So you should expect to see significant data in the next several years on fatty liver disease and its treatment. But at the end of the day, it's really mostly diet, exercise, and weight loss in combination with these things. Patients want a magic pill, but a magic pill isn't going to exist. You're going to need to have lifestyle modifications. And so how do we manage these patients? If you see on the left, those who are low risk, those who have fatty liver without scarring, they can be pretty much managed by their primary care doctors, or their endocrinologists, or their cardiologists. They need to be told about lifestyle intervention. They certainly will benefit from weight loss program. Trials or vitamin E, pioglitazone, not recommended, but there needs to be discussions on cardiovascular disease risk reduction. Those patients on the right with high risk, bridging fibrosis, cirrhosis, they need to be seen by a liver doctor and managed by a multidisciplinary team. They need intervention as far as lifestyle. They need to be sent to a structured weight loss program, be placed on anti-obesity medications, consider bariatric surgery. They may be candidates for vitamin E or pioglitazone. And again, you need to have discussions about cardiovascular risk reduction. And if they're diabetic, the preferred medications are pioglitazone or GLP-1s. And so we're beginning to develop recommended algorithms for treatment. So I'm going to conclude with a couple of overall statements regarding best practice in the treatment of fatty liver disease, or evaluation of. Lifestyle modification using diet and exercise to achieve weight loss is benefit for all. Among patients with NASH, Ideally, you want to have them lose 10% of their body weight, which can result in significant progression of fibrosis. If you're going to talk to them regarding a diet, you should really target a 1,200 to 1,500 kilocalorie diet per day with a 30% reduction at least from what they had been taking before. If you're going to recommend a diet, the Mediterranean diet is the way to go. A low-calorie diet can also be implemented for patients with lean Nash with a lower target of weight loss because they're thin to begin with, somewhere between 3 to 5%. You should absolutely recommend exercise, and patients should have vigorous exercise at least 3 to 5 times a week, but it needs to be combined with diet so that you see the effect. Patients with fatty liver disease should be evaluated regularly for other potential coexisting metabolic conditions, diabetes, hypertension, cardiovascular disease, and those conditions should be managed aggressively. And alcohol consumption should be restricted or eliminated from the diets of patients with fatty liver disease. You don't really want to have two diseases going on. And just to be timely, because this also came out this week, and everyone's discussing COVID. What is the actual effect of COVID on patients with fatty liver disease? And here, at least we have a bit of good news. Patients with fatty liver disease are not at any increased risk of developing severe COVID. So obviously these patients should be vaccinated and boosted. However, they are not at increased risk because of their fatty liver disease of developing severe COVID. So I just like to throw that in at the end. And with that, I'm going to stop. Thank you for attention. And if you guys have a question and answer session, now's a good time. So thank you very much.
Thank you so much, Dr. Bernstein. That was a fantastic lecture. And as someone, I'm an emergency medicine PA who has seen a lot of these incidental findings, this was really informative and great to see.
I am glad.
So we are going to start with our Q&A. Our moderator on the Clubhouse side is going to pick up now. So let me know if you have any issues hearing her sound. Patricia?
Thank you so much, Lauren. Thank you so much, Dr. Bernstein. That was an amazing, amazing lecture. My name is Pratyusha, and I'm the moderator over here at the Clubhouse. We have a lot of questions ready for you, and we're really excited to start this portion. So just a reminder to the audience member, feel free to submit your questions to our amazing moderators via our back channel, and we will get them on queue. So for the first question, I'm going to pass the mic to Lauren.
I have to say I'm having a very difficult time hearing you. So.
Okay. We'll try to put it closer to the mic here, and hopefully that picks up.
Lauren, I hear you great. So
you can hear me great. So yeah, I can always repeat any question. Yeah. So coming from the emergency medicine side and thinking about when you get these incidental findings, what do you think that emergency medicine people should communicate to patients when they have these incidental findings on the importance of follow-up with primary care?
So, I mean, I think that's a great question because everyone who comes to the emergency department is going to, with any abdominal complaint, is going to get some sort of imaging, right? I think most importantly, they just need to be told that there's some abnormality that may be associated with fat or that the liver tests are elevated, then that they shouldn't panic, quite frankly, but they should follow up. And they should be told that, you know, most patients with any type of liver disease, whether it be extremely mild or advanced, don't have symptoms because most will say, nothing hurts, I've never had a problem, you know, whatever. So I think reassurance in the emergency department and then follow up. And most of the time, these patients can be followed up with their primary care provider. They don't need to go to a specialist. They need to be assessed first by the primary care provider. And then if after that assessment, if they felt a need that they need to go to a specialist, they can, they should. But I don't think, quite frankly, it's the emergency department's role, you know, to have these discussions about chronic disease. So they should be referred. ED should be, I have a problem, let's assess it. You need to come into the hospital or you don't. And then if you don't, oh, we happen to incidentally find this and you should follow up. be my recommendation.
Great guidance. Okay, Pertusha?
Thank you so much, Dr. Bernstein. That was an amazing answer. So I'll be asking the next question. So you mentioned that Mediterranean diet is actually best. So can you recommend any other diet besides from that can be beneficial for patients with non-alcoholic fatty liver disease? And a follow-up question, are there any specific factors that should be included in the diet that can be beneficial for the patient? Thank you.
Yeah, so it's a really good question. You would think that they have more things that have been studied, but there have not. Any diet that a diabetic follows is good for fatty liver disease. So low carb, low fat diet, whatever it may be. None of the fad diets have ever been shown to be effective in treating fatty liver disease because they really haven't been studied. The DASH diet, the same thing. So I think you have to use common sense, right? And so the discussion should really center around limiting the amount of carbohydrates that you take, limiting the amounts of fatty products that you take, limiting the amount of alcohol that you drink, although you can cook with it, right? Because it gets denatured and doesn't cause a problem. So, what I tell patients to do, I recommend the Mediterranean diet. I tell them to go online and download something. I tell them to get a book on, what diabetics should eat. And there are lots of those self-help books that are available. And that's really good for patients that have fatty liver disease. It's very difficult to take someone who's 50 years old and make a recommendation about a complete change in diet because people know what they like and they're going to pretty much eat what they want. And so another big component of this is eat what you like, but eat less and exercise, but be smart, right? Talk to them about avoiding the desserts afterwards, unless the desserts are good berries or something. There are things that people can give up that will help. It really centers around how does someone diet to lose weight without going through these fad diets. Because when people lose weight rapidly, they tend to gain it back pretty quickly. The best thing is really behavioral modification. So they change their diet over time and they don't go back. So gradual weight loss is better than, a month of losing weight quickly because most people will come back to that or a higher level at the end.
I see. Thank you so much for that amazing answer. And now I'll be passing the mic to Billy for the next question.
Okay.
Hi. Oh, sorry. Hi, can you hear me?
I certainly can.
All right, fantastic. First of all, I just wanted to say that was another great example of, I really appreciated your emphasis on actionable information. It's really the broader context of the patient you had throughout this lecture. But sort of on a similar note, what do you perceive as the greatest limitation in diagnosing and treating patients with NASH versus non-alcoholic fatty liver disease?
So the question is the greatest difficulty in differentiating fatty liver from NASH?
I sort of meant, what do you see as the biggest limitation in treating these patients with either disease, specific to each disorder?
I mean, the biggest limitation in treating these patients would be two major buckets, which are really quite large, right? One is most of the people with these conditions remain undiagnosed. And so you have to get them diagnosed. And the second, which makes diagnosis difficult, is most practitioners don't even know that this disease exists. And so there has to be significant education to the providers that this is a real disease and that it should be recognized and recommendations, should be made. 20 years ago, we didn't even talk about fatty liver disease. We talked it really only in the context of people who took steroids or people who drank alcohol. Now we've learned that it's a whole separate entity. So there's been, it's new. And so the biggest two issues are patients feel fine and providers don't know much about it. So we really, and we have been pretty remiss in getting the information out there. The liver doctors and the GI doctors know about it, but they're not seeing the patients. The primary care providers and the endocrinologists are the ones who are the primary gatekeepers here. And so they need to be educated. And from there, they're going to be caring for 80% of them, because 80% of the patients don't need referrals. And so that's what I think needs to be done, but I don't have an answer as to how to do that.
Well, thank you. I think it was very interesting. Sorry, my sound cut out.
Thank you so much, Dr. Bernstein, for another great answer. And now I'll be passing the mic to Gayatri for the next question.
Okay.
Sometimes there's some tech issues. I think there might be one.
No worries. I am so used to tech issues. I have, I'm not very good with tech, so I get it.
All right, then. I guess we can move on to the next. We can move on to Herschel, I guess. Herschel, would you like to ask your question?
Yeah, sure. So thank you, Dr. Bernstein, for the super insightful presentation. So I wanted to ask one question that what are the effective medical diabetes management on fatty liver pathologists?
I'm sorry, I lost you. You went in and out. Could you repeat the question?
What are the effective medical diabetes management on fatty liver pathologists?
He said, what are the effective medical diabetes management on fatty liver pathologies?
So if patients have diabetes and fatty liver, first and foremost, they have to get their diabetes under good control. In whatever medication that the practitioners are going to use. Then they need to exercise. So the treatment of fatty liver is really similar to the treatment of diabetes, right? Diet, exercise, and placing on medication. Is there a particular class of medications? Off-label, most of us believe that these patients should be treated with a GLP-1, but I don't have any data to support that. And so what I'm trying to do is, stick to what's available per se, and not have folks start using things off-label unless they're really comfortable. But a diabetic can be treated with the GLP-1, and that will help the fatty liver disease. But first and foremost, again, you have to get the diabetes under control. If you don't get the diabetes under good control, the fatty liver is going to progress. We do know that if you get the diabetes under control, and then you have the components of diet, exercise with weight loss, the liver will stay the same or get better, right? We don't have any magical therapies to use. In those diabetic patients that have Nash, you can use vitamin E, and we do use a host of vitamin E, in these patients, 800 international units a day. And you see on transient elastography significant improvements, and you see significant improvements in the ALT if they're elevated. And this is why it's so important that primary care providers who are caring for diabetics and endocrinologists who are caring for diabetics really know about this condition, because they are going to be the primary managers here. They're the drivers.
I think we have time for one final question. So Pratusha, I'm going to hand it to you for the final question. And I'd just like to note I'm drinking my coffee, and I really liked that point that coffee is A-okay with you.
It's great. Have more. Have a couple more cups.
I agree with you, Lauren. I was so happy to hear that. All right. So for the last question, I will pass the mic on to Ms. Khan.
Hello, Dr. Bernstein. First of all,
Hello.
I would thank you for such a brilliant lecture. I certainly learned a lot. My question to you is for our younger attendees here, just getting into medicine, what inspired you to pursue medicine and eventually hepatology? And has it lived up to your expectations? I would love to hear your thoughts on this.
Sure. So I I trained in internal medicine, and I was very interested in gastroenterology. And then I was exposed to some of the most world-renowned hepatologists who were my mentors. A gentleman by the name of Eugene Schiff, who was the head at the University of Miami, who wrote the textbook, and a woman by the name of Dame Sheila Sherlock, who was in London, who wrote the other textbook. And the discussions that they had around liver disease and the thought processes involved, you know, to be very biased, it's the thinking person's field in gastroenterology. And these people were just so brilliant and so interested and such inspiring teachers that, you know, I latched on to them, and the story continues. And, you know, I'm still in touch with Dr. Schiff. Dr. Sherlock passed away, but I still speak to him regularly, you know, and he's my mentor. So I think for the younger folks, no matter what field you're interested in, it's really important to find a mentor and to, you know, develop a relationship with that person. And that relationship will last a lifetime, which is really great. And then I will call it the legacy stage of a career. You know, my joy is watching the folks I've trained now become professors and become chiefs of divisions and chairs of things. So to me, you know, that's the excitement. So for the young folks, find a mentor, get excited, and just do it.
What a wonderful way to inspire and motivate everyone, especially the ones who are getting into the medical field. Thank you so much, Dr. Bernstein. This is such an amazing way to end our Q&A. I wish we could go on, but however, we are reaching the end of our keynote. Thank you once again for that wonderful lecture on behalf of everyone on Clubhouse. We are incredibly grateful to have you here on MedNews Week. I cannot wait to rewatch this session along with the others. Thank you to all of our panel members and attendees from all different platforms for your participation and questions. If you missed this lecture, fret not. You can replay it here on Clubhouse or on YouTube as well. Lauren, do you have any last thoughts?
No, great lecture. I can't wait to rewatch it again as well.
Thank you guys very much. I appreciate the opportunity. I'll see you. Goodbye.